So I've now basically
take a seat
had,
here.
I wouldn't even call the first consult with my doctor a consult.
Right.
He basically was just like, you got a big problem and I can't help you.
Okay.
He's like, call these other guys. But so I had a consult the other day, Sean.
Yeah, you can take a seat
really
here.
scared the crap out of me.
Okay.
And part of me appreciates what the doctor was trying to do.
Yeah.
But I didn't like how he went around it.
Sure.
So basically, he's a former Army surgeon. And he came in and is like, you got a bad problem. I was like, I know. And he's like, are you prepared for what you're going to have to give up? And I was like, I don't know.
Yeah, what are we giving up? What's on the...
He's like, I might allow you to progress lifting weights up to 25 pounds at some point. I was like, wait a second.
What surgery did he recommend?
He was talking about like relocating muscle to take the place of tendon.
Yeah.
So like shaving some of my trap and tying it over the top, cutting into my pec and making that work for the subscap.
Mm-hmm.
And I was like, okay, like a part of me was excited to hear that because he was the first, I'd read about it,
Mm-hmm.
right? So I was kind of excited to hear that projected or proposed.
Right.
But I'm not willing, like I would rather not get anything fixed, work out until my shoulder fails, get a shoulder replacement, and because I can't lift anyway. So if you're telling me you're going to do all this surgery and I can't lift,
correct.
Why not just go for the next 5, 10 years, 2 years, whatever, until it just wears out and then I can't lift anyway?
Yes, and it's your right shoulder.
Yeah.
Just watching you move it around, I'd be very, like you look very functional.
Yeah, dude. No pain.
Yeah.
No pain. Like I can feel it catching a little bit.
Sure.
I ruptured one of these biceps tendons a long time ago, but I think I ruptured another one because in my MRI report from November of 2024, it indicates that the long biceps tendon is where it's supposed to be, and now it's saying it's gone.
Got it.
But in the surgical orders, bicep tendinosis is prescribed, so the doctor's going to go in there and try to move at least the one that just recently, the one that ruptured years ago, that thing's shot.
Yeah.
Right? They're not going to be able to mobilize it. But so, like, I didn't mean to interrupt you.
No, you're good.
So after this doctor prescribed this really crazy procedure, I was like, hey, I've had multiple consults. I was like, the first consult I had, the doctor said he's going to go in. Even though the tear in the supraspinatus is pretty big, he's going to try to mobilize it. If he can fully mobilize it without too much tension, he's going to reattach it. If he can partially mobilize it and make the hole smaller, he's going to do that. And he's reasonably confident that he can repair the subscap. And the doctor that prescribed all this crazy stuff, he's like, well, that's what I'm going to try too. He's like, I'm just telling you what happens if all of that fails.
Yeah.
I was like, well, I kind of appreciate that, but like, are you telling me that the first approach is like a 5% gonna happen, and this other's 95%? Because those look very different.
I think unfortunately that's probably a question, like to get the likelihood is that they probably just can't answer it until they get in there, right? Because there's no way to tell. They know what they would need to do to make that happen, and there's no way to tell whether they can or not until they get in there and do that, right? So then the question then becomes, do we try that? And if it doesn't work, abandon and just say, hey, I want to continue on like this. Or, yeah, like you said, if it doesn't work, then we escalate to this, crazy procedure. At the end of the day, this is a situation where there's probably no black and white answer, which means that at the end of the day, you need to feel comfortable with whatever it is that you decide, right? What I'd like to do, no matter what, especially if you are leaning towards trying something surgical, is I would like to take your case and consult with 2 other surgeons that I know, and just see what they think, so I can get a little bit more. That particular surgery you mentioned where they do all the relocation, I've heard of it. I don't know anything about the outcomes, and I'd love a surgeon's perspective that I trust that's in that industry to say, hey, here's why I like it, here's what I don't like it, to get more information. Because obviously you take if you've got one person's opinion on the surgery in terms of like what it would look like, what the outcomes are, and so yeah, I think more information on that end would be better.
And just for point of reference, the two surgeons that, number one, have both said I can go in and fix your subscap with reasonable confidence.
Yeah.
And they're like, we just don't. One guy said the supraspinatus, he can't do anything. The other one said he's going to try.
Right.
Those are both, like, one of them's a shoulder fellow.
Right.
The guy that prescribed all this crazy stuff, he's a little bit younger. I'm not trying to play conspiracy in my head, but I'm like, is this guy trying to go balls to the wall and write a paper on me?
Yeah.
Like, I mean.
Yeah. I mean, definitely that surgery is a newer thing. It's not something that is, most shoulder surgeons don't do it. The good news is that both the people that I would ask are also shoulder specialists.
Okay.
So we can at least know they can, give me their honest opinion on.
I would love that.
Yeah, I'll do that after this for sure. I'll shoot them a text. And I'll try to, if you said you have the actual surgical thing, I'll take a screenshot of that and send it to him like, hey, here's the situation. My bias, just from watching you move your arm, is to do the first thing you said, which is to just continue trying to just forget about the surgery. Because as we talked about before, looking at your imaging, when I see fatty infiltration in the rotator cuff muscle itself, that tells me that tear has probably been there for a while.
So that was the suspicion, especially on the supraspinatus.
Yeah.
I'm getting mixed reports on the subscap.
I don't worry about subscaps tears as much.
But I can't press.
Yeah.
So like if I've been working out with my daughter, and so if I'm on the bench, even with like 20 pounds, if I don't get a really solid retraction, I can feel this arm just going like this.
Yeah. You just don't have good shoulder stability because the rotator cuff is obviously missing. I mean, there's a possibility that with a lot of training and practice that gets better.
Okay.
But there's a very good chance that no matter how much you do, it's not going to be the same as the other side, right?
And I'm kind of preparing for that. Like I'm preparing that it's gonna look different. I'm preparing that my training's gonna look different.
What are your thoughts on because what you'll have a lot better success would be like on machine pressing.
I've started working on that too. Like I don't want to fully abandon the dumbbells. Just I like the feel.
Sure.
I like the fact that I'm hitting 3 or 4 muscle groups, not one.
Right.
Right. So there's a little more efficiency there. I've already started wrapping my head around the weights that I hurt myself with. Probably not playing with those anymore. Right. And that's probably not a bad thing.
Yeah.
Right. Like I was telling some of your trainers that work here that I've kind of become friends with. I'm like, I don't need to bench 350 anymore.
Yeah.
I don't want to look like a can.
Yeah. Well,
right?
Mission accomplished. You look like you work out, which is great. And obviously, I mean, that's the thing. Look at it this way. Bodybuilders, very few of them train like super heavy dump. They're all machine based. It's like the good thing about training with machines is that there's less degrees of freedom.
Right.
Which means your rotator cuff doesn't have to do as much. You can generate force in the bar, and it's safer, right, in terms of shoulder stability, right? So I see that as a much more reasonable, like, hey, this is something that you will almost surely get back to and feel comfortable with. Dumbbells, I'd have to look at it. But from what you're describing, I think that's a tough ask.
Certainly, like I said, with pressing, I haven't even, and here's the crazy thing, the day of the injury, it hurt, but not to the point with the damage that I have.
Yeah.
Not on that scale.
That's why I think a lot of, and for reference, JC, so we've talked before, sorry, but he.
I'm sorry. If you have any questions, if you have questions, please ask.
But what we know so far is that he has a complete tear of, several of his rotator cuff, but he's had issues with it before, and then he had an incident, how long ago? A couple weeks ago?
It's been a month.
A month?
Yeah, it's been a
where
month.
He was dumbbell pressing and everything kind of gave out. And so then that led into getting imaging and consultations and whatever. And the results are that, supraspinatus, one of the rotator cuff tendons is completely torn. The subscap, I think, is there. It's
a full thickness tear, but it's only 7 millimeters.
So there's still some connected there, and then there's some propagation over to the infraspinatus, which is the back side of the rotator cuff. So all I to say is, The hard part is that the tendon is so torn and retracted that it's difficult. They can't guarantee they can repair it. But that being said, is when a muscle has fat infiltrated into the muscle tissue, it usually means that it's been there for a while. So there's a pretty good chance that the tear we had on MRI, it could have looked like that a week before the injury, and you know.
Well, and then the doctor that I'm scheduled to do surgery with, he also, number one, he didn't love the MRI.
Yeah.
He said, because I asked him, I was like, what degree is that fatty infiltration? I said, because the report doesn't mention it.
Yeah.
I was like, but somebody I trust mentioned it, and Dr. Edwards, who says that the subscap is or the supraspinatus is unrepairable, I'm having to believe that that has something to do with the fatty infiltration. And he's like, number one, I don't love the imaging. The angles are a little bit off.
Is it yours? Oh, that's okay.
Sorry.
No, you're good.
He's like, the angles are a little bit off.
Yep.
And he's like, I don't love the sequencing. So he wouldn't answer how much fatty infiltration was there. He's like, but you see this cavity? He's like, I can see probably 50% atrophy.
Yeah.
He's like, and that didn't happen over 4 weeks.
Right. That's been there for a while.
And then this front delt, I've noticed I've been developing an imbalance for probably 6 months.
Right.
And when I first started lifting post-surgery, I was progressing pretty good with overhead dumbbell press, and then it stopped. Then all of a sudden, like I was doing 60s, 4 sets of 12. Then all of a sudden, I could 50s.
Right.
And then what happened was I could progress up to 40s, but then as soon as I grabbed 50s, I couldn't get from here to here.
Yeah.
If you came up behind me and moved me to here, 15 reps, no problem.
Right, just getting it to
this range of motion, strong. Right here, nothing.
Yeah. The severity of angles of the shoulder without a rotator cuff to provide congruency of the joint, you just have no power output. And I'll tell patients it's kind of like trying to shoot a cannon out of a canoe, right? There's just nothing to generate, or trying to climb a mountain in quicksand, right? There's just nothing to generate force from. Yeah. And so that's really common with not just rotator cuff, anything that causes instability of the shoulder or of a joint is you lose power development because there's just nothing to generate force from. And then if you can get into a position where you can actually generate force, it's easy, right? And that's the part that's why dumbbell pressing is going to be a bigger challenge than machines, is because the machine, you can set it up, it's only moving in one plane. So all the force you generate is moving in that plane. You don't have to control for any other degrees, and so it's a little bit more stable.
Also, too, what I've been working on too is I can really focus on retracting. So consciously holding my shoulder where it's supposed to be, whereas when you're pressing with dumbbells, you're kind of floating.
Yeah.
Because the weight's kind of moving, which is why you're building your stabilizers.
Yep. But you got no stabilizers.
That's what I was gonna say.
That's why they call it free weights, right?
Right.
Yeah. So you have a surgery scheduled, and is it with the guy that wants to do all the big stuff?
No.
Oh, different guy.
Yes.
This is the guy that is going to try to reattach it.
Correct.
Who is it?
His name is Dr. Michael Cusick.
Yeah, I've heard of him.
Fondren.
Yeah. Okay. I don't know him well, but I have heard of him. And you had a good interaction with him?
I did, and I had I had a consult with Dr. Edwards. I can't remember his first name. He was my first consult with Fondren.
Okay.
When I did some research, and take this with a grain of salt, they're both ranked very highly. Like if you type in, show me the top shoulder surgeons in Houston, they're both up there.
Right.
This other guy that wants to do all this cowboy shit,
yeah,
he's nowhere to be found.
Right.
Which then I was like, wait. But he's with Methodist, and how I got to him was I had some friends that had work done with Dr. David Lintner.
Oh yeah, I know
Lintner. The Astros guy.
Yeah.
He referred me to this other guy.
Got it.
I don't know if he referred me because his schedule was too busy or he can't help me.
I'm sure. Yeah, I'm sure it's probably a little bit of both. Lintner doesn't do. He may do. It's mostly your kind of like more traditional rotator cuff sports stuff. Yeah. this obviously to this type of, this is almost like a shoulder preservation surgery, right? Where it's like, we don't want to do, most people would say, hey, you're going to be a shoulder replacement candidate, but you're young and you're active, so there's just, you're kind of trying to preserve, right? That's kind of what it is, which there's just less people that, hey, what's up, Ashley? There's just less people that specialize in that exact category. So all that to say, we already said it, but I'll feel better about yay or nay on that surgery once I talk to surgeons that I trust and get their input. So when is the surgery scheduled?
August 24th.
24th. Okay, you got a month. And are you leaning towards doing that no matter what, or where are you at? Because I just want to make sure you feel good about what.
As I stand right now, unless you go to some guys that you trust that are highly specialized shoulder guys that are like, hey, kind of the idea is both of the guys at Fondren said that there's a strong possibility at some point in my future I'm looking at shoulder replacement. He's like, it's not guaranteed. They're like, but it's kind of looking that way.
That's on the horizon.
Right. The guy that wants to do all the crazy stuff, he's like, 100% you're getting your shoulder replaced. It's going to be a reverse shoulder replacement. You're not going to be able to lift your arm above your head. And I'm like, that's not what these other guys are telling me. I understand that that's a possibility.
Yeah.
But you're telling me that that's an absolute gonna happen.
Yeah.
I was like, I'm young. I plan to stay active. I've got 2 surgeons basically saying that if you modify your training, you could do nothing.
100%.
I had both of them say, what do you want to do?
Yeah.
And I was like, so you're not telling me I have to? And they were like, no.
Yeah.
They were like, one of the tendons not looking good. The other one we can repair, but then you still have a massive tear.
Right.
You're still going to have an issue. I can't fix everything. It's up to you. Like, because like what you said, they're like, you're functioning crazy well without a ton of pain. You're already going to have arthritis because the ball's moving around.
I was going to, yeah. I think this is an N of 1 case, because most people with an injury to the rotator cuff as sizable as yours would not have as much function. That's just because most people don't exercise regularly. Most people that are going to see the surgeon for rotator cuff repairs and stuff like that, if we look at the statistics, it's going to be people over the age of 55 that are relatively inactive. So you're kind of most, again, 99.9% of people with rotator cuff repair like this would not be moving their arm that well, right?
The doctor said he's like, when he saw my report,
they don't match,
and knew that I talked to Edwards, he called Edwards and he's like, can this guy move his arm? And he was like,
oh yeah.
Like the guy's still he's still lifting.
So. And that's why there's no great blueprint, because let's just look at, if we lay it all out there, if we've got a sizable rotator cuff repair or sizable rotator cuff tear like you do, there's extra motion in the joint, which leads to more friction, which leads to more arthritic changes, meaning that the likelihood of needing some type of intervention surgically for the joint itself in the future is higher. However, some people have severe arthritis and don't have pain. It really comes down, it's less about pain and more about function. So the goal is to keep range of motion, to keep, as much motor control and strength as possible, and for as long as possible, right? So that it becomes a very difficult question to answer, and it becomes very difficult to predict the future because there's just so few people that are in your exact situation, right? So I think what based off everything we've talked about so far, what I think the best option to do would be to see how you feel over the next 3 to 4 weeks with some exercise, and I'll give you some recommendations on training. If we feel good that it's probably worth exploring the base surgery, right? What I would talk to the doctor about, and it sounds like you already have, but we'll go in, no matter what, they're gonna be able to repair the subscap. So that's done. And then try to repair the supraspinatus. And if they can't, leave it alone. At the very least, the subscap repair and them debriding a little bit of stuff should provide a slightly more stable shoulder, right, for you to deal with. And then I would say you just do your absolute best to take care of your shoulder, continue with training and all that kind of stuff, and try to push off any potential shoulder replacement for as long as possible. Because let's be honest, if you're 70 years old and need a shoulder replacement, Like you could still exercise, you could still train, you just won't be able to do, the dumbbell overhead press and stuff and those kinds of things, right? I've had plenty of patients that have had reverse total shoulder, and yes, do they lose range of motion? Absolutely. Are they still able to train and do strength training? Yes.
With the reverse?
Absolutely.
Really?
Yes, absolutely. They just can't.
Everything I read is like you can't put this under load. Like it's not designed to be under load.
You can load it. You just can't load it in certain positions.
Okay.
And so, ironically, the reverse total shoulder is probably more stable than the regular total shoulder. The sacrifice is that we don't have range of motion because you reverse.
Show me what.
Yeah.
In theory,
so
where would my range of motion
on
be?
average, so this is 90 degrees. On average, people after about 2 years after a reverse total shoulder, on average, get about 107 degrees of motion. So that would be about here. Okay.
Okay.
I've seen patients with as much as 120, 125 degrees of motion.
Okay.
Functional range of motion for the shoulder is about 120 degrees, meaning if I want to be able to reach for things, grab stuff, very rarely are we like reaching this way, right? Now, incline press, shoulder press, dumbbell fly, those are all things that we typically do with more, so we just have to do other things, right? And that has to do with because the reason they call it reverse is they're reversing, instead of the ball being this side, it's reversed. Now the ball is on the socket and it's all backwards. And so that results in slightly less overall motion of the shoulder, but it's more stable. And you would definitely have to get a reverse because you need an intact or a mostly intact rotator cuff to do a traditional total shoulder.
I was going to ask you that because the cowboy doctor basically said you absolutely have to have a reverse.
Yes.
The other guy seemed to kind of hint that I could do a traditional.
It would only be if they were able to salvage your supraspinatus or the majority of your rotator cuff tendons now. But generally speaking, if you have an insufficient rotator cuff, which that's you to a T, a reverse total shoulder is what you would typically need.
Well, but that's encouraging to hear that, like, everything I'm reading and what this other guy's telling me is reverse total shoulder, never lift again, can't lift your arm above here. And I'm like...
And again, think about the population that they're studying for this. These are people over the age of 70 with severely arthritic shoulders and no rotator cuff. And they're deconditioned.
Your point is if I can delay this 5 to 7 years with a minor intervention right now...
Yes.
What does a reverse shoulder look like 7 years from now?
Yeah, it could be better. And also, I don't think it'll be, if anything, it'll be probably hopefully much further down the line than that. Because I don't remember, I wasn't looking at your shoulder joint, I didn't see a ton of severe arthritic changes at this age.
Well, see, and that's another thing too. Both Edwards and Cusick said, okay, there is some irritation.
But it's not.
But they were like, it's something they both said it's something to pay attention to. The other guy's like, it's catastrophic. And I'm like, that's not what I'm... And then he also told me, and he was the first one, the guy that wanted to do the crazy surgery, he's like, I can almost dislocate your shoulder. That tells me that your subscapularis has been torn for a long time. I said, you're the first doctor. I said, that's inconsistent with my MRI. My MRI that I had in November of 2024 says there is no problem with the subscapularis.
Right.
So
somewhere between there and...
18 months?
Yeah.
Maybe. But we're not talking 5 years. He's like, well, I can almost dislocate your shoulder. I was like, half my rotator cuff is missing. I was like, of course.
There's no stability.
Down and you're leaning on me and you're telling me that you almost feel it dislocating.
Yeah.
That doesn't surprise me at all.
Right. I mean, that's essentially what kind of happened with the first incident, right?
Correct.
Is you lost stability, the weight went back, and then, your shoulder subluxed a little bit, right? Yeah, I think the good news is you've got good muscle tone everywhere else. And one of the side effects, you think about bodybuilding, we say, oh, you're toned, right? You've got hypertrophic muscles. A side effect of hypertrophy is increased resting muscle tone, meaning that you're just existing and there's tone, there's tension on your muscle. For us, we want as much deltoid, pec, lat, anything that's not a rotator cuff, as much tension as we can get which means we want to train them, we want them to be developed. That will help provide extra stability to your shoulder.
So the muscles will be picking up where the rotator, not 100%, but they will be compensating where there is no tendon.
Correct. Let's say what's interesting, and we know, you had mentioned, I felt like my deltoid was I can guarantee you that your shoulder has adapted to no rotator cuff over probably a long period of time, because the supraspinatus, its main job is to help initiate elevation.
Okay.
So when people have, typically, if they have a tear of their supraspinatus, especially if it happens like after a fall or acutely, they can't raise their arm. They try to raise their arm and their shoulder just shrugs up this way.
Okay.
And you're over here. So that means what's doing that motion is all except your deltoid, other muscles are doing that motion. It's not your rotator cuff. So that's why it tells me is like your body has compensated for not having a rotator cuff for at least long enough to figure out how to lift your arm and do stuff.
Yeah.
And so if it's not hurting and you've got full range of motion, I'm just very hesitant. If it's not broke, don't fix it, right? So I think, if they can repair the supraspinatus, I'd say, yeah, let's go for it. But if they can't, I would still say, given what you look like, is to try your best. You modify your training a little bit to reduce things that may cause extra micro motion, which is going to be free weight stuff, right? There may be still some free weight stuff we can do, but then we substitute the stuff we can't do with machine-based training that's more stable. You can still develop your muscles. Then we have increased hypertrophy. That keeps our function good. It minimizes how much wear and tear we get, which starts pushing back shoulder replacement, reverse total shoulder stuff, hopefully as long as possible, maybe forever, right? We don't know. Okay, so I think kind of what I want to do, obviously, is I want to look at your shoulder. We'll talk about training program. Your program is going to be really important to make sure that you feel confident about what you can do and how you can modify to continue to train, right? And then after the call, like I said, I'll talk to, his name's Dr. Gregory and Dr. Shoup. I'll call them. And then see what they think about that kind of radical procedure.
We'll also get their opinion. I can leave you all my paperwork.
Okay, cool.
I don't have any until August 24th. I don't have any more consults.
Okay, cool.
So I'll leave you all of my surgical orders, all that stuff. That way you have everything
Sure.
in front of you, and then just text me and be like, Matt, I'm done with it. Come get it.
Sounds great.
That way this is what they're going to try to do.
Right.
Thoughts on all of it. Radical procedure and what's currently prescribed. That
Sounds
would be
good.
Very helpful.
Yeah, absolutely. I'll do that. I appreciate you letting me have that. That'll help. Yeah, and then we'll go from there.
Okay.
Do you have any other questions before we take a look?
No.
Cool. So let's see. I mean, I can already, again, it's just funny for me, just watching you move your arm naturally, it just doesn't, just complete disconnect from what the MRI says.
And it's crazy, no pain, it's not even pinching.
Yeah.
I get a little bit of a pinch here.
Yeah.
If I do light laterals, I'll get a little bit of a pinch here.
Yeah.
That's it.
Pretty awesome.
I have, I don't have, if you were to stand up,
Yeah.
I don't have that strength.
Yeah.
And also here, here.
Yep. It's hard.
That's
some of that is probably your shoulder. What happens when the body's great at figuring shit out. And so we don't have as much stability of the rotator cuff, that's gone. What we tend to see is that the shoulder capsule will start to stiffen up a little bit. It starts restricting motion. And I think that's probably what's leading to, you probably noticed maybe your rotational movement is.
I've been able to put my hand behind my back for 15 years.
Yeah, it's just been going on for a while. But that's all good. That just helps your shoulder be more stable. If you got an itch on your back, you got to use your other hand. But, we're looking for.
Rub against the post.
Same. I have the same problem. I had the same problem. I'll find a corner on a wall or something.
Standing in the gym,
Yep.
like this.
It's like a bear,
What's wrong with you?
Yeah, I can't. It's funny. I think I saw something on Instagram or something where they had a bunch of bodybuilders. They put a sticky note in between their shoulder blades, and then they're stuck. They're never getting that off. Might as well jump in the shower or something. That's it. So, okay. Well, let me take a look at your motion. I'm gonna have you start. You can stay seating. I'm just gonna have you lift your arms up overhead. Any discomfort with that at all?
Tightness.
Okay.
And now another thing. I feel tightness and have been prior to the incident in my rear delt.
Yeah. It's probably because your rear delt is screaming to try to elevate. Any discomfort there at all? If I push down and rotate, any problems there?
Okay. I'm feeling it. I'm feeling tight.
Yeah.
I want my wife to rub my rear delt like that.
That's it.
But there's no pain.
Put your arms like this. I'm going to try to push this way. I want you to push out. Okay, that's good. Arms straight out in front. Hold it there. It's pretty good. Put your arms this way. And then I want you to try to rotate your arm in towards me.
In?
Yeah. Okay, good. And relax. And then you can just let your arm basically go limp. Can I roll this
Yeah,
up?
do you want me to take my shirt off?
Actually, yeah, if you don't mind, that'd be great. I just want to see what the shoulder blade and your deltoid look like. My guess would be, yeah, I mean, so you've got some overdevelopment of the anterior part of your deltoid, and also there's another assisting muscle, coracobrachialis, that helps elevate the arm, and it is hypertrophied like crazy. So you're probably, lift your arm up, and then do this arm. Yeah, so do you mind if I take a picture of this so I could show you? It's just fascinating. The body is like, okay. So, do you see this? Mm-hmm. So that is your coracobrachialis. It is a relatively small muscle that's supposed to help assist with like shoulder flexion elevation, and it has hypertrophied like crazy.
On this side.
Yeah.
Because it's doing all the work.
Yeah, you can see, look how big it is.
Yeah.
So so that is the muscle that is basically allowing you to elevate your arm.
Okay.
And so, again, we've already talked about this, but that kind of compensation does not happen in a month. This has been something that's been going on. Because you actually have great strength out here, which traditionally if you had a complete supraspinatus tear, that shouldn't happen.
Okay.
But it is because you're just using other muscles to do it, basically, which is pretty cool. But then, yeah, just let your arm completely relax. I'm just gonna kind of like pull it straight down. So there's like a mild sulcus, but this is like a test to see kind of how passively stable. Yeah. And it's definitely a little bit looser, but not nearly as bad as I was expecting. And again, I think it's just because we have so much hypertrophy of your other muscles, which is great. And then I'm just gonna kind of move your arm around and you just let it stay limp. Yeah.
I have a hard time.
That's okay. Yeah, so we do have some mechanical stuff going on, that's for sure. You feel that clicking and grinding? Yeah. So that is kind of like, that's what causes increased arthritis. It's just because normally when we elevate the arm, the rotator cuff contracts, and then the rotator cuff keeps the shoulder in the socket and it stabilizes it, and then our bigger muscles like our deltoid and our pec and our lats pull the arm and everything kind of glides normally. Without the rotator cuff, there's not as much pressure pulling inwards, meaning as we go to lift, this is kind of just sliding around, which is...
when I hear the clicking, I try to, regardless of what I'm doing, really retract.
Yeah.
Even if I'm cooking lunch for my daughter, and I hear it click, I will deliberately retract.
Right.
Trying to hold it where it's supposed to be.
Yep. Yeah, I mean, I think whatever you're doing is working. So all this to say, I would just really lean away. If it was me, I wouldn't do anything.
You wouldn't do anything.
I think,
so let me
I'm trying to pretend if I was in your situation. I mean, yeah, I may consider doing just trying the supraspinatus, right? But then I also think like, well, if it's already retracted, it's not going to get any worse in 3, 4, 5, 6 months. So maybe I would try a little bit longer and see what happens. But
so Dr. Cusick thought, and I probably misspoke, he thought that both tears were re-tears. So his initial was exactly that. Work out 3-4 months.
See how you
feel. He's like, train responsibly. Because if you have another catastrophic event, you could blow whatever is left, and now we don't have a choice.
Right.
He said, train for 3 or 4 months. If you can deal with it, we'll do nothing.
Right.
He's like, if you don't like it, we'll go in and do what we can. It doesn't really change the outcome. We're looking at a re-tear. To be fully transparent, before my first surgery, I was battling depression, was suicidal, started doing nicotine to kind of get through that. Didn't realize how horrible nicotine was for tendon bone healing. So I've now only been off nicotine for 4 days leading up for surgery. So that's a big variable that I wasn't aware was so detrimental to what I was trying to do. And so, but then when I told Dr. Cusack, I said, no, I said, from my understanding, the subscapularis is a fresh tear, which there was a major failure of the supraspinatus, partial dislocation. And he's like, well, that changes things. He's like, if that is truly a fresh tear, he's like, I kind of want to go in there and fix it.
Yeah.
And give you
as much stability.
Rather than having half of a rotator cuff.
Right.
3/4.
Right.
Or 70%.
Right.
Because I know that there's some other, fraying and stuff going on. I know my shoulder's not perfect anyway.
Right.
But he's like, if this is truly a fresh tear, he's like, that changes my calculus quite a bit. I would want to go in and repair it.
Right. I think that's so super reasonable. My only concern about doing it, any surgery, just given how functional you are, is we lose those adaptations because we just can't. So you're going to be in a sling for 6 weeks, gradually moving out of it, right? And it's going to be several months before you can start getting back into some of the training you've been doing before. And then what happens to the like that compensation that I see of the core that starts to reverse itself. Now they're all reversible, you can get it back, but it will probably be a slower recovery than someone who had just an isolated subscap tear, because we have to allow time for the tissues to heal, and then we have to give it time to adapt back to where it was before.
I know we haven't really spent a ton of time together, but I am way more type A than I realized. Like, my concern is not necessarily doing the work to get this compensation back, if that's reasonable.
Right. Oh yeah, it'll happen.
It's more along the lines of you're training too much. Like, I've even talked to some of your trainers in here. I'm like, hey, I might need to hire you
just to keep you
to tell me to do less.
Yeah, 100%.
Honest to goodness.
Yeah.
3 months ago, 7 days a week.
Yeah.
Like upper lower splits, 2.5 hours lifting, like 7 days a week. I'm 47 years old.
Yeah.
Like,
definitely, and again too, like learning how to train, regardless of whether you get surgery or not, learning how to train the shoulder appropriately is going to be the most important thing for regardless of whether you get surgery or not. So, well, I'll tell you, your shoulder looks remarkably good for what we know is going on there, right? If I didn't know that you had that big of a tear, I would tell you, hey, we've got some grinding, some mechanical symptoms. We're going to work on strength. We're going to, that's what I would say, right? I would have never guessed in a million years that we would have significant rotator cuff injuries like we do, right? So all that being said, I think we start off. Well, I'm going to give you stuff to work on, and that will, at the very least, help to make sure we've got a decent kind of starting plan for the shoulder. I'll talk to the surgeons, see what they think about both, situations. And then I would just, for you, I think either getting the subscap fixed and trying the supra and calling it there if they can't do it, or giving it a little more time are both just easily justifiable options. And then it comes down to whatever you feel most comfortable with. That's the most important thing. It's your body, it's your shoulder. You want to make an educated decision, right? Because there could be it's like hindsight, right? It may turn out great. It may be a little bit of a problem. We don't know whether it's tough to say.
Well, and obviously being, bound up for at least 3 months, not lifting and sitting like this for 6 weeks, the thought of all of that sucks. I'm willing to do that if that gives me 7 to 10 more years on the backside.
Absolutely.
Right. But if you talk to 2 more surgeons and they're like, if he keeps strength training and deals, modifies, you're going to get that 7 to 10 years anyway, I would just assume not have to stop lifting for the next 6 months. And I know that sounds crazy, but
yeah, no, I think it's very reasonable.
It's so important to my mental health. It's
absolutely. Well, like I said, you've done some remarkable. Like, your body has responded really well to what you're doing for it. In fact, like I said, I mean, that's why that's what makes these cases so hard, is because there's like only a handful of people that have probably been in a similar situation as you with that significant of an injury that have been able to, compensate so well for it, right? So, but I think we have a good plan. Do you have any other questions? Cool. So you put your shirt back on. What I'll do is we're gonna try a couple exercises. I just want to see what they look like for you and how they feel. And then when we finish today, I'm gonna send you an email and I'll include some video links like, hey, here's your warm-up routine for your shoulder. Here's your daily routine. And that way you have stuff to work on.
I'm gonna hit the restroom.
Go for it. I'll meet you back here.
And that's another thing that I've been really working on is before I even touch the upper body, which I've been horrible about previously, I'm foam rolling against the wall.
Yep.
Band work out, retraction.
Good.
Face pulls.
I think a lot of
10 minutes before I even touch a weight. So
that's great. I think a lot of it will be, it'll be the tempo and how we dose those exercises. All those are great exercises, but we want to dose them where we do them really slow and controlled and even probably like isometrically as opposed to repetition volume based. Okay. So we'll talk, we'll go ahead and we'll talk about it. Yep, sounds good.